Greg. If you make the right diagnosis for someone, great. But if you haven't thought about 5 other biologically plausible explanations for their experience, you're really not a good doctor for them.
Welcome back, every bendy body, to the Bendy Bodies podcast. I'm your host, Dr. Linda Bluestein, the Hypermobility MD, a Mayo Clinic-trained physician dedicated to helping you navigate Ehlers-Danlos syndromes and complex chronic illness. Today, I'm joined by Dr. Dacre Knight, who is not only an expert in EDS, HSD, POTS, and mast cell disorders, but is also joining me as a recurring co-host. Dr. Knight recently became the medical director of the UVA Ehlers-Danlos Syndromes Center, which is officially partnering with Bendy Bodies. Today's guest is Dr. Gregory Plotnikoff. Dr. Plotnikoff is such a wealth of knowledge, and today we're going to be focusing specifically on vitamin D. This is such an important topic because so many people have persistent pain, sleep problems, all kinds of problems with their mood, and vitamin D can play a really, really important role. As always, this information is for educational purposes only and is not a substitute for personalized medical advice. Stick around until the very end so you don't miss any of our special hypermobility hacks. Here we go. I'm so excited to be here today with Dr. Plotnikoff and, of course, again with Dr. Knight. We're going to be talking about a ton of things related to vitamin D, and I think Dr. Knight is going to lead us off.
Yeah, very excited to have you here, Dr. Plotnikoff. Just to get started today, and I know this is something that you have gone through quite a bit in the past. Speaking of all the different, mechanisms of things that can go wrong for someone with EDS and HSD, a lot of things that come up are questions about lab work, blood tests, electrolytes, vitamins, minerals, and things like that. But specifically related to vitamin D, this is something that I look at and we test for and discuss with patients. Let us hear from your expertise about, first, so starting, what is vitamin D? Why is it considered a hormone rather than a vitamin? And maybe just a little bit of background for us to just get this started.
Well, thank you. It's a great honor to be here. And I love the topic of vitamin D because it's the single most cost-effective medical intervention in North America and is so overlooked. And so vitamin D might be overlooked because someone called it a vitamin. It really is a hormone. Vitamins are cofactors in enzymatic reactions. Hormones regulate gene expression, and vitamin D regulates probably over 2,000 key genes in our body. Things related to mood, memory, energy, sleep, bone health, and so much more. And because it's free from the sun on certain days, it really is so cost-effective. And you mentioned about kind of the data. There's like over 100,000 articles in the National Library of Medicine on vitamin D-related concerns. So almost any concern that anyone presents with, there can be a link with vitamin D. And so going by the understanding that fundamentals first, then pharmaceuticals, is kind of, vitamin D is just foundational to anything. And the problem is we could be really deficient in it. And that's the great challenge. You say, well, what do you mean by we? Well, if we did a study of 14,500 Allina Health System employees, 60% were low, 30% were very low, and 6% were profoundly low. And you could say, well, that's Minnesota. You're halfway to the North Pole. But I just put an article out today from Karachi, Pakistan, and showing huge percentages, 23% were profoundly low. And so in a sunny country, you can still be vitamin D deficient. Los Angeles, Houston, Tampa is kind of like, it's too hot to go outside, so we're inside. Or we work long hours indoors, or on and on. So, so the goal, I'm hoping that people listening will hear today that actually vitamin D is low cost, low toxicity, and represents good, um, effective self care.
Yeah, that's what I always turn to too. What are the easy things we can pull, right? That they may just be sitting right in front of us that we can observe this, we can make a change, and it can affect some good positive outcomes. So yeah, I think that's definitely been my experience. So, and this next question, I've got some ideas of my own, but I certainly really just want to hear from your experience. And you touched on it too a little bit as far as why people have low vitamin D's who live in sunny climates. But do you see that relate to symptoms directly based on their climate, based on their occupation, based on their environment, and things like that?
Well, I think particularly for this audience, pain, musculoskeletal pain, um, uh, stress fractures, shin splints, tendinopathies. Uh, these are great things. Now, in the general overall population, is kind of like it's joint injuries, it's tibial plateau fractures, it's hip fractures. Much of the research has been done on elderly people and issues around falls and joint replacements. But for kind of young active people and with multiple joint concerns or actually frank injuries, um, vitamin D is still overlooked. And here's what I feel really passionate about. Back in back in the 1980s, I was a freshly minted doctor, and I was working in clinics where I was seeing people with chronic, nonspecific musculoskeletal pain, and I was feeling so incompetent. I had done 4 years of med school and 4 years of residency, and I felt completely unprepared. And I said, "Did I miss some lecture? Did I miss something? What's going on?" And so back in the 1980s, one went to a library, and I went through journal after journal after journal trying to find something. I came across an article entitled "Hypovitaminosis D: Slow to be Diagnosed in Immigrant Women." And this was the British Medical Journal. And it was a story about 6 women who had moved from India to London and then developed these horrible musculoskeletal pain syndromes and fatigue and weakness and that no one could explain. Woman even got a bone scan looking for cancer, and it looked like she had widely metastatic cancer. And she said, "Ugh, I'm out of here. I'm returning home." Returned home, got better, as if the cancer disappeared, and then returned to London and got worse again. And so someone raised the issue, maybe it's vitamin D. And they found, in these 6 women, they had really low vitamin D levels, and giving them vitamin D and things resolved. I said, well, these sound like the people I'm seeing in my clinic. And
That's what I was going to say. Yeah.
yeah, and so I was working in 14 different languages, and so with immigrants and refugees, and I'm just going, okay, everyone with unexplained musculoskeletal pain, 6 months or more, I'm just getting a vitamin D level on them, and everyone started coming back really low. And in fact, so I decided, okay, we got to combine this. So I published on the first 150 people I saw, showing 100% of African American, 100% of Native American, 100% of East African, 100% of West African, 93% of Southeast Asians, and 80 something percent of whites were severely vitamin D deficient. And we found 5 people with undetectable levels, with one woman was being treated with high dose neuroleptics because of, and they thought, well, this is a somatoform pain disorder. one person underwent $250,000 worth of, and this is kind of like late, I guess, just say not late 80s, late 90s dollars. He got cardiac workup, he got spinal surgery. Oh, his pain never went away. He came to clinic, we measured vitamin D. It was undetectable. We got him on vitamin D replacement, and he is just kind of like, it's gone, it's gone. It's just like, yes. So for everyone listening, please hear my plea. Let me share one story that's unforgettable. This is a young woman. She's 35 years old, mother of two. She loves working out. One might call her kind of like a gym bunny. She just loved, but for 5 years, she had progressive musculoskeletal pain and weakness. And she went from doctor to doctor. Oh, you're anxious. Oh, you need morphine. Oh, you're depressed. She's just like, no, I just want to get better. Don't give me these meds. I just want to get better. Find out what's going on. Finally, she makes her way to me. Things had gotten so bad that she could barely stand up at the kitchen counter to wash dishes, and her two children were taken away from her. She comes to see me. I go out to greet her in the waiting room, and to shake hands, she pushes herself up and says, "Hi, nice to meet you." I said, "Oh my God, it's vitamin D deficiency." And I swear to you, I kid you not, one bottle of vitamin D, and she got her two kids back.
And she had been going to the gym, like she's
Well, she had been
avid
until she
exercise
just got
until she couldn't. Yeah.
until just the pain and the weakness was just too much. And so that's an extreme example, but I don't want anyone listening to this podcast who has any kinds of musculoskeletal pain. Please don't don't please have your vitamin D measured. And why I published on these 150 patients with vitamin D deficiency. It's went on to become one of the most highly cited articles in the history of the Mayo Clinic proceedings, and its accompanying editorial also is one of the most highly cited articles as well. And it hasn't changed practice. So it's not going to come from the medical hierarchy. It's going to come from people saying, hey, it's a reasonable part of the differential diagnosis. I'm a fellow human being. I'm at risk for low vitamin D. Let's measure the vitamin D. And because frankly, there's no physical exam for it aside from someone who's profoundly vitamin D deficient. And so the question is, are you low? How do you know? You can really only know by measurement. Dosing does not matter. Blood measurement does.
Oh, that's great, and it's exactly again what I was referring to earlier. If we can get something that's just right there under our noses, and we can capture that, and we can find a simple, effective, safe treatment, and goodness, and avoid extra waste of money or any other invasive treatments, then that's exactly what we're going for. And so you said measurement, and I just wanted to pick up on that. What is there a specific lab test you do for that?
There's only one lab test for that. That's the 25-OH vitamin D. That is there are multiple vitamin Ds out there, from the pre-vitamin D in our skin to what's circulating in our blood that's activated by the liver. It's then activated by the kidney. So there's a variety of different measurements possible, but it's the 25-OH vitamin D is the one that's really gives you an assessment of vitamin D status in the body.
And you know what? In my experience, and I guess you too, do you check it on all of your patients?
Absolutely, yeah.
Yeah, likewise. And I've had some kind of question, well, or maybe even some Medicare coverage, like even maybe not want to cover it. Right? Is that also been your experience?
So Medicare coverage differs around the country, and it's very political. It's not based on science, it's based on politics. And there's lots of reasons why insurers may not cover a vitamin D test. So, for example, it's not covered for chronic pain. It's covered for osteoporosis or kidney failure or hyperparathyroidism or sarcoid or something. Um, but you can purchase it from your local health plan. So if it's not covered locally, the retail price for vitamin D, if you go to Alina Health Plan or others, is well over $225. The wholesale cost is around $20, and so it's garbage to pay that much money. I think Quest will do it directly from their direct cash pay, direct to patient type practice for about $70.
So I've got one more question, if I may, before I know Dr. Bluestein's going to have some ready to go. But uh, you know, I was thinking about as you were describing it earlier about those who, again, different climates, Minnesota versus Pakistan or elsewhere in the world, and thinking to myself, I would wonder if Dr. Plotnikoff can tell us about sun exposure and how much sun exposure would be ideal, and maybe before the London Tourism Board comes after us here, maybe then you can explain then what your management might be in different settings. If you were in London, practicing in London, or if you are practicing in a northern climate, how would you change that based on if you were say in Florida or somewhere else?
Well, Minnesota is 45 degrees north, so we're exactly halfway to North Pole. London's about 52 degrees. Edinburgh is even further north than that. But you think about 45 degrees north, that's really the Spanish-French border. And so it's kind of for things. Here's the key point. In Minnesota, well, actually, the key point is what matters is the angle of declination of the sun. And I guess I can't really illustrate that so much there, but the lower the sun is in the sky, the greater the distance light has to travel. And in that travel, the small part of the spectrum, the ultraviolet B between 290 and 315 nanometers, has just the right amount of energy, or not, to actually go to a certain level in our skin and break open a double bond, which goes from pre-vitamin D to a kind of another kind of the vitamin D that's ready to be activated by the liver. What counts is how much energy does that light wave have? So if it's going through clouds, if it's going through smog, I don't know if you've
Not
ever
all light waves are equal then.
right. So picture this. Have you ever flown at an airport and where you've looked out the window and seen this like brown haze over the city?
Yeah, sure.
Yeah. It's a vitamin D umbrella. And so it's been documented because of the industrial pollution in Guangzhou, China, that the vitamin D producing rays in Hong Kong have gone down by 20% over the last couple decades. So a general guide is to recognize that one, you can't make vitamin D through glass, impossible, no matter what time of day or year. You can't make it through clothing. You can't make it through sunscreen, and you can't make it through the winter, at least in North America. Now, and here at halfway to North Pole, tell people roughly you can make it between tax day, April 15th, and Labor Day, early September, between the hours of 10 and 3, if you're outside with exposed skin, no sunblock, but safe sunning. It's just like no burning, please. If you're pinking up, they say it's too much. But another general rule is if your shadow is shorter than you are tall, then you have a good chance of making vitamin D that day. But for the people out jogging and walking before work early in the morning or doing it late afternoon, you can't really make vitamin D there. It's good for other reasons, but But January, high noon, you stark naked in the middle of the park and not make a drop of vitamin D. And so, how then do you get it? Well, supplementation is actually a great way to go.
Well, that answers that, and we might have stirred up some of our dermatology colleagues in Florida, but at least we have absolved the London Tourism Board now, so it is possible to live with good vitamin D levels in northern climates.
It is, but I should just mention a recent study just published a couple weeks ago out of Birmingham, England, demonstrated a huge percentage of pregnant women with profoundly low levels. And earlier in Edinburgh, Scotland, 100% of the people in one primary care practice were severely vitamin D deficient, published in the British Medical Journal. And um, and so yes, and so another key point is the darker your skin, there's more likelihood that your uh, near ancestors were more equatorial than more North Polish. Um, um, the darker your skin, the more sun you need to make the same amount of vitamin D. So, if one, so Minnesota has a lot of Somali refugees. They can't make any vitamin D. And a recent study done at one clinic demonstrated that the average vitamin D level among Somali women in a prenatal clinic was 6. Now we want to see above 30, and so yeah, so there's some real concerns that even though we are aware of these issues, they're not being implemented by the health systems, and it's a line item veto issue. It's by some bureaucrat in the system not recognizing that there's a huge racial disparity in this issue.
Well, it's something. It's important to know, right? It's important to make these observations. So, we're treating all patients, as best we can. So, thank you for that. That's excellent points.
And I have to say, as somebody sitting here with a headband on because I had major skin cancer surgery last week, um, the whole sun thing is really tricky. I got a lot of sunburns growing up in Southern California, and I'm now paying the price. I've had 10 basal cell skin cancers. I've had 4 Mohs surgeries, including a redo Mohs surgery. So I'm really curious to know more about the balance of sun exposure, and are there any downsides to supplementation versus, getting it naturally? Because I now am, it's a little late. The cow's out of the barn, but I'm super aggressive now with, sunscreen and hats and all of that because I've had enough of this nonsense with all of the skin cancer. But so is there a downside to getting it through supplementation? And then can you tell us more about what the goals are? And then my last part of this multi-part question is also, can you comment, Dr. Plotnikoff, on the genetic differences in processing vitamin D? Because I understand that that's a factor as well.
Well, yes, it's a multi-layered question. And before we get to that multi-layered question, let me point out, low vitamin D is definitely a risk factor for multiple cancers. And it's been suggested as a significant risk factor for skin cancer as well. Now, also, since we're on the topic of nutrition and skin cancer, the New England Journal of Medicine had a very interesting randomized controlled trial a number of years ago around nicotinamide and basal cell. And that low nicotinamide levels were definitely linked to increased risk of basal cell, and supplementation actually reduced the frequency in a high-risk population. So we don't hear much about vitamins in general in healthcare settings because I think the three of us will agree that is just kind of like, that's not the mission. I mean, nutrition may, you're going to say, oh, Plotnikoff, you're so cynical, but okay, bear with me. Nutrition may be important for health, but it's not for medicine. so, so,
Yeah, we
So,
expect people to get it as they go about their day, right?
yes,
We expect it
yes.
just happens.
It just happens. As one dermatologist told one of my patients, I kid you not, he said, "Eat more broccoli." What? There is no vitamin D in broccoli. No,
That's good. Yeah.
there's all kinds of reasons to eat more broccoli, but not for
Yeah.
vitamin D. No one's going to get enough vitamin D in their food unless they're drinking 2 gallons of milk a day, and I don't recommend that for anyone. And um, so supplementation is a great way to go. As we learn more and more that skin is an endocrine organ, that there are other reasons why it's good to have sun on our skin, safe but safe sunning, no burning. All kinds of things relate to mood and multiple other effects we don't need to go into. If one has the option of being outside, and many of us don't, but if you have the option of being outside, that is always good and reasonable. But you don't really know how much you're getting. Here in Minnesota, we do know if you play hooky in the summer and go to the beach, you can get about 20,000 international units that day, as long as you don't burn. But but for most people with supplementation, a general rule of thumb is, and this is based on Minnesota experience, but it would apply to Los Angeles if you're indoors all day, and Houston and Tampa, and definitely Maine and Alaska and the like. But in general, 1,000 international units for every 35 to 40 pounds of weight. You say, well, wait a second. The RDA doesn't have anything to do with weight. And I would say, well, where did that RDA come from? Well, essentially, here's the science behind it. One article published in 1940, an issue of JAMA, a multi-page review on the topic of rickets. And in that review article, there's a couple paragraphs. Why do these white kids in Boston not have rickets? Oh, they're taking cod liver oil. Oh, how much? A tablespoon. How much vitamin D in that? 400 international units. And for many, 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 many decades, that was the standard. That's where the 400 international units came from. It was repeated in 1953 pediatrics article and really taken as gospel truth. And even when the Institute of Medicine did a review on vitamin D a number of years ago, they only raised it to 600. And it was based on some really faulty reasoning, as if there's no difference between black and white, young and old, thin and big, Anchorage and Tampa. It just makes no sense at all. And they did some hand waving and some mathematics, but practically on the ground, it doesn't make any. That does not translate to be enough for anyone. I like data, and so here's some specific data. In a study I did of 6,800 women of childbearing age working in the Atlanta healthcare system. So this is a subset of the 14,500 we studied. We asked the question, okay, and we did the vitamin D level twice, 2 separate springs. Um, and um, and then we asked what dosing people were taking. And then we asked the question for BMI less than 30 and BMI greater than 30, what dose was needed to guarantee that 97.5% of that subpopulation would achieve a bare minimum level of 20 nanograms per ml? And the answer is for women under 30, a BMI of 30, it was 2,500 international units per day, or 4 times the RDA. And for women with BMIs greater than 30, it was 4,500 international units per day, or, what's that? About 8 times the RDA. We submitted that article to JAMA and it was rejected. They said, oh, this was 92% white. The population is 92% white. They very few smokers. They all had health insurance. They all had access, and they all had kind of some foundation of knowledge. This is not generalizable. The article was rejected. Just it left me so depressed. I
That's understandable. And I want to just clarify something because I don't know if other people are confused since I'm a little bit, I don't want to say confused, but I just want to clarify. So you're saying that if the BMI was less than 30, they needed 2,500 IUs in order to have a minimum level of at least 20. And if their BMI was greater than 30, they needed 4,500 because you also had said earlier that there was something about 1,000 IUs per 30 to 40 pounds of weight. And I just want to make sure because BMI versus actual body weight are two very different things. So I don't want people to be confused with all the numbers because these are important. These are very important things for them to know about.
The general guide of 1,000 international units for every 25 to 30, 35 to 40 pounds is based on general clinical experience. Looking at the BMI less than 30 or greater than 30 was an epidemiologic study, and the general guide is you look for what will guarantee 97.5% of a population will be sufficient in a nutrient, and that becomes the kind of the guideline. And because you're always going to miss 2.5%, apparently.
And before we go to the break, I bet a lot of people are listening to this and they're fascinated. And I started checking vitamin D levels immediately. As soon as I started my clinic, I did recognize that this was a low-hanging fruit that we definitely needed to address. So I'm so glad we're finally having this conversation. It only took me, 6 years to get here. Okay. Hopefully no one's keeping track of that. But no, I've been talking about it, but not in this depth. So before we go to the break, though, I would love to know what is the goal we should be aiming for? Because you've talked about, greater than 20, greater than 30. In a perfect world, if you could dial in a number for people, what would that number be?
Okay. So this is a very important question for which we need really solid data that does not yet exist. And it may be for different goals. In general, we want to see everyone above 30. There's epidemiologic evidence to support levels that ideal levels may be 40 to 60. Um, and this goes back to the question I didn't answer about the genetic variability among us. There are vitamin D breakdown enzymes. There are issues with body mass index as a fat soluble vitamin. There are issues with vitamin D binding proteins. There are issues with vitamin D receptors through the body. And so we're talking really kind of general guidelines. Specifics will be coming, in the, AI will probably, kind of give us some guidance on that at some point. But there are multiple factors or confounders in things. So, but in general, we can say that, yes, above 30 for everyone. And in general, we can say it's likely 40 to 60 is good for a population. It may be different for subpopulations, but we don't have data to guide that right now.
Okay. And is that nanograms per ml? What are the
Yes.
units? I just want to
Yes.
make sure. Okay. Great.
Yes. Well, thank you for clarifying that because there's also nanomoles per liter, and the nanograms per ml is 2.5 times higher than the nanomoles per liter. Or excuse me, the nanomoles per liter is 2.5 times higher than nanograms per ml.
Okay, excellent. So those units. My dad was an aeronautical engineer, or is an aeronautical engineer. Kind of once you're doing it, you're always doing it. So he would really get me on the units thing if he's not going to watch this episode, I don't think. But if he did, okay, we're going to take a quick break, and when we come back, we are going to talk more about vitamin D and do you need to be concerned about toxicity? How does vitamin D interact with connective tissue and so many other things. So we're going to take a quick break and we'll be right back. Thank you so much for listening to Bendy Bodies. We really appreciate your support. It really helps the podcast when you like, subscribe, and comment on YouTube and follow, rate, and review on all audio platforms. This helps us reach so many more people and spread the information to everyone. Thank you so much again, and enjoy the rest of the episode. So we're back with Dr. Plotnikoff and Dr. Dacre Knight talking about so many things. I want to say all things vitamin D, but obviously in this duration of conversation, we can't get to all things vitamin D, and I don't want to be misleading. Before we move on to some specific, hypermobility, connective tissue type things, I just want to ask in terms of dancers and athletes. They experience higher rates of things like shin splints, stress reactions, stress fractures, etc. Can you tell us a little bit about how vitamin D and low levels could play a role in that, and also in tendon health or soft tissue resilience? What are some things that athletes and dancers should know?
Well, thank you for asking. I'm a big dance fan, and so I get chances to meet with dance troops as they come through Minnesota. And recently it was the Joffrey, and before that it was Hubbard Street and ABT and others. And I ask, whenever I get the chance to go to the receptions for these artists, I always ask about vitamin D. And it's just like a one-track mind, but I'm so concerned because these awesome artists, athletes, no one's talking with them about vitamin D. And in fact, there are even dance, clinics around the country. And I asked, you go to, do they measure your vitamin D? No. Are you taking vitamin D? Well, I'm taking multivitamin. I started a couple weeks ago. What? No, please, please. Vitamin D is critical for muscle function. It's critical for bone. It's critical for tendons, among a zillion other things. And no one wants to be, missing a performance, or much less missing months of practice because of a vitamin D deficiency related concern. And so I'm really hoping that the word gets out that at least measure your vitamin D if you're not taking vitamin D already every day at a decent level. We know from the U.S. Olympic team that if you're going for a gold medal, you need a normal vitamin D level. Or we know from the NFL that here are these multi-million-dollar year athletes. The lower the vitamin D, the higher the risk of on-field injury and the slower the recovery. I'm a hockey fan of sorts. I grew up in Chicago. The Chicago Blackhawks never won. And a number of years ago, they actually all got measured for vitamin D. Now, these are top athletes, again, performing at very high levels, but they're indoors all the time. Hockey rinks are indoors, and in the winter, if they're outdoors, they're not getting any vitamin D from there, and much less they're all suited up. And they were all found to be low in vitamin D. They were all started on vitamin D, and that year they won the Stanley Cup. First time in 50 years. And so low cost, low toxicity, you don't want anything holding you back or putting you at risk. Now, the U.S. military has reported that in 19-year-old recruits, I think this is in South Carolina, is kind of like the risk of stress fractures was profoundly higher in people who are low in vitamin D. In fact, nearly everyone with stress fracture had low vitamin D. So it's all types of people engaged in physical exertion. I pulled an article out here, just published in May of 26. Association of vitamin D deficiency and supplementation with clinical outcomes in multi-tendon chronic tendinopathy, a retrospective clinical trial. Bottom line was vitamin D was critical for recovery from a tendinopathy. They had higher pain scores if their vitamin D was below 20, longer disease duration by twofold, over 8 months versus 4 months, and a higher prevalence of chronic tendinopathy of 80% versus 24%. So my plea to all athletes, to all dancers, to people engaged in strenuous activities, Yes. Yes. Vitamin D might be really good for your pickleball.
And I think maybe you just spilled the secret of how the U.S. men's hockey team won the gold medal this Winter
Yes.
Olympics. They got their vitamin D, right? Yeah, that's great. Thank you, Greg. And I do want to ask about vitamin D toxicity. But one quick thing is, and I was thinking about it as we were going through the discussion about with Dr. Bluestein, just sharing the effects of what we know can happen if you get too much sun exposure. But I was thinking again about my question for you about northern climates, management of patients in northern climates versus those in sunny climates. And really, truth be told, as you pointed out, we really have to be cognizant of it all climates because of how much time we spend indoors nowadays, right? And there's a potential for so many people to spend their all waking hours inside, whether they live in Tampa, Florida, or Los Angeles. So yeah, just another point of clarification to my questions for you. But yes, so we've been expounding upon all of the benefits of vitamin D, and we're all going to be ready, reaching for the bottle as soon as we can. But yeah, let's get it clear. Is it possible to get too much vitamin D?
Oh, sure, it's possible. There's a woman, kind of a wild story was a woman was working in a milk bottling plant in the UK and had decided she wanted to get rid of her husband. So she was taking vitamin D and kind of like putting it in his soup. And he got millions of international units and got sick. She got arrested. But it took millions of units, and at best, he just got acutely ill. It in in more than it's kind of what I've been in medical practice 40 years now, and at least since kind of the 90s, been working in vitamin D. I've yet to see anyone with a real vitamin D toxicity. Now, there have been infants who accidentally were given a zillion units, and that is toxic. And we know we use vitamin D to kill rats. How is it that vitamin D got a reputation as a rat killing poison? Well, it's because you overdose the rats with vitamin D, and that is toxic, and it's toxic to infants. Um, but it's really hard. Um, I've seen people at 10,000 international units a day, and I did never recommend that much unless someone is profoundly deficient to begin with. But I've seen people with 10,000 international units a day who've been on self-dosing for years and come back with a level in like the 90s or low hundreds. The known toxicity from rat poison ideas is if you become hypercalcemic. And so here's the more likely thing is if you're taking in a lot of calcium, and let's say someone's been told to take, 1,200, milligrams of calcium a day, and you've got a high dose of vitamin D, the most likely complication that could come from that would be like kidney stones. No one wants a kidney stone. Uh, um, um, but part of the thing is this recommendation of like 1,200 or 1,500 milligrams a day of calcium was based on vitamin D deficient women. And Robert Haney at Creighton did a study where he uh, looked at calcium absorption with people with a vitamin D level of 20 versus those same people with of absorption at vitamin D level of 30. And it showed that going from 20 to 30 improved calcium absorption by 65%. Oh, this 1,200 international unit or 1,200 milligram recommendation for calcium, does it apply to everyone? Well, if it's based on vitamin D deficient women, hmm, I'm not so sure that's the sorry. No, there is a mandatory 500 milligram a day loss of calcium, it's believed. And so we need at least that. But high dose vitamin D and high dose calcium, not a good combination.
Yeah, I've seen that in my practice. Yeah, definitely.
Yeah. So the big point is that we want everyone to remember is dose determines poison. We don't know what the blood level is without measurement. So this is why a measurement is so important. So if someone says, "Oh, yes, we live in a more is better culture," and Plotnikoff said, 3,000 a day, but I'm going to do 20,000 a day. Well, that's not a good idea. Um, so working with an informed health professional or getting measurements really are important guidance. And we have to remember that vitamin D also works very closely with magnesium. And it's Linda, getting back to your question about um, kind of the genetics and things. We know magnesium is a critical cofactor in many of the transformations of vitamin D, both its production and well as its breakdown. Um, and then magnesium and vitamin D also work together at the muscular level, at the cellular level, at the sarcomere level. It's very, very important for function. And vitamin K is also really important as part of this as well. So it's really more of a kind of a complex of things that really work together.
So as soon as you said that, I'm picturing the emails.
Oh, good.
What exactly which vitamin K, what dose, magnesium. Of course, we've talked about magnesium before a little bit, but if you could share some specifics, of course, knowing that this is not medical advice, this is, general information. Everyone needs to consult with their own team. But I know people are going to be asking these questions. I'm always like, listening for this. Oh boy, this is going to be something that a lot of people are going to ask about.
Okay, well, good. Well, thanks for pointing that out. So I never promote any commercial products or purposes, so I won't use any brand names. However, in general, I also focus on food first. And I just mentioned there really isn't any vitamin D in food. It's just you cannot. It's just not enough. No matter what any kind of site says, it's just not nearly enough there. Um, Magnesium sources. When we think about anything that's green and leafy, inside that chlorophyll is a magnesium. Magnesium found in just kind of a non-processed kind of whole foods diet will have a fair amount of magnesium in it. Vitamin K is also think about green leafy vegetables. And I like vitamin K2. There's vitamin K1 and K2. And some people have difficulty converting K1 to K2. And so I lived for many years, I lived in Japan, where I was a professor of medicine in Tokyo. And I happen to like natto for breakfast, and it's stewy, it's gooey, it's messy. You can't eat it without having a spider web of goo on your face. But um, but that's a great source of vitamin K2, among other things. But what do? I do a magnesium glycinate. I do a vitamin D and K2 combo, and that kind of covers everything right there in 2 capsules. And I do the best I can with diet. But it's 15 minutes a day is just 1% of the day. And there are many days where I do not have 15 minutes outside. And yeah, shame on me. It's not a good thing. But do people say, "Oh, you spent a fair amount of time outside." Well, all right. Every 15 minutes is 1% of your day. Did you make it to 5% of your day today?
That could take a lot. So what I'm hearing you say, Dr. Plotnikoff, is that vitamin D is safe. I mean, in theory, you could have too much, but what happens really when we get concerned about is, as I mentioned, I see in my clinical practice too, is the concern about hypercalcemia, because what you've now taught us is that there's almost like an acceleration effect of calcium absorption, right? As the vitamin D is coming in.
Yeah, so the kidney stones is a big issue, and there are certain medical conditions where you have to be really careful. Sarcoid being one. Um, um, Hyperparathyroidism is a really interesting one. Um, I swear I've seen people who have had their parathyroid surgery, and but it turned out to be it looked like it was vitamin D deficiency that was causing the patient that led to the surgery. So that's why I really like the idea about partnering with an informed health professional. And this is my soundbite of the day. Self-diagnosis and self-treatment sometimes results in self-malpractice.
That's a good one. I like that.
Yeah.
And to carry that further too. So yes, emphasizing your shared partnership with your health professional. But this is fairly easily managed. You're monitoring labs, you're getting a supplement, and you're getting on the right path. And it is low hanging fruit. So by all means, and if it's happens to be cash paid, it's only $70 for a lab test. So yes, to go then a little bit forward on that. Let's say we're doing those things, and you mentioned some of the symptoms that can happen with low vitamin D. What's your thought process then if you've got someone well managed on vitamin D, but they may still be having some of those symptoms?
Okay, well, that's the thing is, I like what one of my mentors said. She said, "Greg, if you make the right diagnosis for someone, great. But if you haven't thought about 5 other biologically plausible explanations for their experience, you're really not a good doctor for them." And so I'm always thinking, what else? What else? What else? Part of the messaging here is that what else can be vitamin D deficiency that people aren't considering. But there are so many other things. That's why working with informed health professionals is so important. Is as a thought partner. You bring your ideas, bring your research, and I think thought partnering is a very empowering way of doing things. Um, I particularly dislike the term provider, whereas it really makes it sound like, oh, I'm handing all my health over to someone else who do the work for me. And I tell people, fellow health professionals, don't be a tow truck. Now, here in Minnesota, where we got snowy roads, people slide off the road all the time. And you've got 2 options. One is you can get out the cat litter to put and the snow shovel and kind of dig and get some traction and maybe call some friends to help push you out. But you can get out under your own power. Or you can call AAA and just a tow truck gets you. And I think every time I hear the word provider, I'm thinking people are thinking of their health professional as a tow truck, someone who's going to do all the heavy lifting for
Sort
them.
of handing it over to them. Yeah.
Yeah, it's disempowering. And so everything we're talking about, everything your podcast is about empowering people. Knowledge is power, and everything here is kind of supporting people to get optimize their health. And yes, there's can be a gazillion reasons why people can have musculoskeletal pain and weakness, fatigue, and tendinopathies and more. And we need to consider all the biologically plausible dimensions, vitamin D being one of many, but it's something that unfortunately is easily overlooked because of this term vitamin. And vitamins it sounds too woo-woo.
Yeah, that's a perfect lead into what I was gonna ask next, which is, you know, uh, if somebody nowadays, we have all these direct to consumer lab options, as you guys were discussing earlier. Like somebody could go and get their own vitamin D level checked without an order. Back when I went through medical school and residency, these of course were not options, but they are now. Not that we want people to feel like it's all their responsibility, because it has to be a balance, right? It has to be a balance between those things. Not everyone can afford even the $70 for a vitamin D test. So I love that we're giving some ideas for people. Again, they need to consult with their own team, but just some general, guidelines that are in the literature in case they're not able to afford the vitamin D test. But let's say somebody can afford to pay for a vitamin D test, and maybe they want to check some other labs as well. There are things that you, Dr. Plotnikoff, kind of consider to be, kind of standard for your patients that have chronic pain, inflammation. I know now I'm getting a little more greedy. Mast cell, POTS, EDS. What are kind of the general labs that you would see as being foundational in addition to vitamin D?
The Plotnikoff top five. Okay. So
We're
number
full
one.
of sound bites today, right? This is great. Love it.
I can only think in sound bites. but but actually, so vitamin D, yes. Um, I like essential fatty acid profiles, omega 3s and omega 6s. And I see people who have profound omega 3 deficiencies. I can also see people with profound omega 3 excesses. And same thing with omega 6s, either too much or too little. And you can really only assess that through a blood test. So that's kind of a big one. I like to see reactive protein for general inflammatory guide for things. When it comes to musculoskeletal and joints, the ANA autoimmune screen, kind of stands out. So those are kind of four easy ones to do. The fifth one is homocysteine. And homocysteine is a very inexpensive blood test that is a great indirect marker of how methylation is functioning. And methylation is a key pathway in our body relevant to mood, memory, energy, sleep, bone health, and a zillion other things. There are over 200 methylation dependent enzymes in our body. And high levels of homocysteine are not good. And they're definitely linked to all kinds of neurologic issues and more. Um, Now, this could maybe be a whole nother podcast, but let me just share with you that despite the fact that that the circumstantial evidence is very high about homocysteine being a major risk factor for neurologic issues, um, and blood clotting and mood issues and so much more. Very, very few people measure it. And at two meetings of the meetings of the grand poobahs, the geeky internists, the American College of Physicians, two times I've been at the conference and asked about homocysteine. And the first time was, huh, not aware of aid data. Next question. And that was a world famous professor of neurology. And you're in a room of 900 geeky internists, the average age in their 50s. So they have both a personal and professional interest in this topic. And I said, gosh, thank you for this presentation. Um, you didn't have enough time to talk about nutrition metabolism. So thinking I'd throw him a softball, I said, could you please address homocysteine? It's low cost measurement. It's easily addressed by, over the counter nutritional issues. It's so strongly linked to dementia and so many other things. Could you please comment on it? And that was, not aware of any data. Next question. So, because there's a long line behind me, I wasn't going to be rude, but on that day in 2019, there were 987 articles tying elevated homocysteine levels with dementia. And that was in National Library of Medicine. Today, it's over 1,200, including international consensus statements saying, well, there's nothing else we can do. At least do that. So, you say, Plotnikoff, do you have a bit of an agenda? I'm just kind of like, yes. Low cost, low toxicity interventions that can make a big difference. So the vitamin D, the fish oil, the CRP, these are kind of they make and by fish oil I mean by the omega-3, omega-6 profile. Autoimmune screen if that makes sense, and homocysteine. These are these. If I was doing a foundation panel, this would be key elements, the center of everything. Because in my 40 years experience, I can say these are ones that have led to the kind of biggest insights and breakthroughs for the least amount of effort and cost.
The Plotnikoff 5. I love it. That's it. But and I keep thinking, I'm just gonna have to go back and listen to this recording again myself because I keep thinking of questions as you're talking and trying retain the information. And I get so excited because you got this encyclopedic knowledge of these things. And one thing that has perplexed me, and I just want to hear your input on it. So, well, actually, a couple things. But first, do you prefer daily vitamin D supplementation or weekly? I know that there's some differences there. How do you approach that? Just to start.
Well, thank you. That's a big point. So a lot of people, um, they say, "Oh, your vitamin D is low. Here, let me prescribe ergocalciferol, ergocalciferol, 50,000 international units once a week." Um, so back, back in the 90s when I was first exploring this, I was one who came out and said, treat with ergocalciferol because um, it has such a short half-life. So ergocalciferol, it comes from ergosterol and mushroom membrane cell walls exposed to ultraviolet B. They'll turn it ergocalciferol or vitamin D2. Um, in our body, we have vitamin D3, but it's close enough and it does the job. And I'd recommended that because back in the back in the 90s when 400 international units going to 800 seemed scary. um, this is what recommended. The once a week is great, but 2 weeks later it's gone. And so it was, I felt safe recommending it because if we got in trouble, it would be gone so quickly. But no one ever got in trouble. People tend to underdose that. Some people really require 50,000 twice a week and plus 5,000 a day of D3 on top of that. But D3 is what you buy when you go to the grocery store. It says vitamin D or vitamin D3, they're one and the same. That's cholecalciferol, and that's bioidentical to what's going on in our skin.
And you just answered my second question, so thank you.
Yeah, okay.
That's it. What do you see in the store?
Yeah.
Okay, got it.
Yeah, so vitamin D3 has a longer half-life, but I tell people if you go out for wonderful, Labor Day picnic and get lots of sun, here in Minnesota, your vitamin D from that picnic is gone by Halloween. So I do like daily, just makes it, daily things like brushing your teeth, it just gets done once a week and just kind of like, we're all too busy to remember what day of the week is it?
That makes sense. As you know, we like to wrap up every episode with a hypermobility hack. Do you have a hack for us? You've already given us some hacks, but do you have an additional hack for us? And then can you tell us where we can learn more about you, where people can find you online or in clinic?
Okay. Well, I practice at Minnesota Personalized Medicine here in Minneapolis, Minnesota. And our practice here is focused on complex, chronic, mysterious illness. So it's kind of like, so if I come across as a little geeky, that's really where this is my contribution to the planet. When people are facing really complexity, they've made the rounds, and I said, well, it's not the right kidney. Go see the left kidney doctor. It's kind of like this is where I add value, and the team here, Dr. April Lind and Dr. Tara Doyle, we enjoy being meaningfully helpful for people with challenges. And am I in the 21st century yet? Kinda. There's LinkedIn. There's kind of, I think our clinic has an Instagram and a Facebook account and things like that where we post things. Certainly, I post on LinkedIn every so often, particularly during the horrors recently in Minneapolis. That was a important site. But a hack. Well, I think because vitamin D is free from the sun, I like this idea of if you're outside and your shadow is shorter than you are tall, then you can make vitamin D. And so it's free, safe sunning, no burning. But a lot of days we don't have a shadow, and many days or many times of the day, our shadow is much longer than we are tall, and we just can't make vitamin D then. So
Very good. Well, thank you so much for sharing your knowledge with us. You obviously have deep knowledge on so many different topics. I feel like we could talk about, homocysteine as a whole separate episode, and so many of these other things, the fatty acid profiles and things like that. So we really appreciate you taking the time to share this information with us today about such an important topic that I think so many people will benefit from. So thank you.
thank you both. I really appreciate this, and I hope that this podcast, this particular one, I know all of them are really good, but I hope this one is meaningful for people. And so if it is meaningful, please write Dr. Bluestein, Dr. Knight, and let them know and comment. And if you can also, if you generate a question that from this, I am most open to questions.
I'm super excited to tell you about the Bendy Bodies Boutique. I am so proud of our fierce styles and flexible designs. These are created by hypermobile artists for hypermobile shoppers. There are so many fun items from clothing, accessories, home goods, and my favorite are the bags. I especially love the Weekender tote with one of the EDS Tough designs. Whether you're shopping for yourself or someone you love, there's so many options to choose from. A portion of the proceeds goes to support EDS nonprofit organizations. For more information, please visit bendybodiesboutique.com. Thank you so much for listening to this week's episode of the Bendy Bodies podcast. If you'd like to go deeper, I share additional education, clinical insights, and resources in my newsletter, The Bendy Bulletin, which you can find on Substack at hypermobilitymd.substack.com. You can also help us spread the word about connective tissue disorders by leaving a review, sharing this episode, or sending it to someone who needs it. These small actions truly make a difference in raising awareness about conditions that are still widely misunderstood. And don't forget, full video episodes are available every week on YouTube at Bendy Bodies Podcast. As many of you know, I offer one-on-one coaching and mentorship for both individuals living with connective tissue disorders and people caring for them. You can learn more about these options on the services page at hypermobilitymd.com. You can find me, Dr. Linda Bluestein, on Instagram, Facebook, TikTok, X, and LinkedIn, all at hypermobilitymd. As part of our collaboration with the UVA Ehlers-Danlos Syndrome Center, we also want to share some of their helpful resources. For questions or appointment inquiries, you can contact the UVA EDS Center at ruvaedscenter@uvahealth.org. Again, that's the letter R as in Robert, UVA EDS Center at uvahealth.org. You can find answers to common questions at uvahealth.com/support/EDS/FAQ. Our incredible production team is Human Content. You can find them on TikTok and Instagram at Human Content Pods. As you know, we love bringing on guests with unique perspectives to share. However, these unscripted discussions do not necessarily reflect the views or opinions held by me or the Bendy Bodies team. Although we may share healthcare perspectives on the podcast, no statements made on Bendy Bodies should be considered medical advice. Please always consult a qualified healthcare provider regarding your own care. For more information about the Bendy Bodies program disclaimer and ethics policy, submission verification and licensing terms, HIPAA release terms, or to get in touch with us, please visit bendybodiespodcast.com. Bendy Bodies Podcast is a Human Content production. Thank you for being a part of our community, and we'll catch you next time on the Bendy Bodies Podcast. Thank you so much for watching. If you enjoyed this video, give it a thumbs up and leave a comment below. I love getting your feedback. Make sure to hit that subscribe button and ring the bell so you will never miss an update. We've got plenty more exciting content coming your way. And if you're looking for more episodes, just click on one of the videos on the screen right now. Thanks again for tuning in, and I'll see you in the next episode.